Okay, let's dive right in. We've got these two cases, Lydia and Richard. Lydia, she's 70, had heart issues before. Now she's tired, breathless, needs pills to sleep, has some leg swelling.
All right. Classic signs.
And there's Richard, 81, smoker, also tired, also got the swollen legs.
Okay.
But he also has a swollen neck vein and an enlarged liver.
Ah, okay. So similar symptoms on the surface, fatigue, edema. But those other signs point towards, well, potentially different underlying issues.
Exactly. And it all seems to come back to this core problem, heart failure.
Yeah, simply put, the heart just isn't pumping enough blood to meet the body's demands. That's the gist of it.
And there are two main ways this happens, right?
Broadly speaking, yes. You've got systolic failure, that's a pumping or squeezing problem. And then diastolic failure, more of a filling problem.
Gotcha. Squeeze versus fill.
And either one can cause blood to back up, leading to congestion. That's where the term congestive heart failure, or CHF, comes from.
Okay, let's break down systolic first. The squeeze problem.
Right. So the heart's main job is pumping blood out. That's cardiac output. Think of it as a flow rate.
And that depends on heart rate and how much blood gets pushed out with each beat.
Exactly. The amount per beat is the stroke volume.
Okay.
And stroke volume is, well, it's related to how much blood is in the ventricle, the main pumping chamber to begin with. We measure the percentage that gets ejected. That's the ejection fraction.
And normal is what, 50 to 70%?
Yep, somewhere in that range. Healthy heart pushes out a good chunk of the blood inside it with each beat.
So in systolic failure, that squeeze is weak, meaning less blood gets out.
Precisely. Stroke volume goes down, and that key number, the ejection fraction, also drops below normal.
Which means more blood is left behind after each pump.
You got it. That leftover blood increases the volume in the ventricle just before the next fill. That's the end diastolic volume, EDV. It's higher.
And more volume means more pressure, too.
Exactly. The end diastolic pressure, EDP, also goes up. There's just more blood stretching the chamber walls.
And what usually causes this kind of failure?
Often, it's damage from a previous heart attack, ischemic heart disease. Scar tissue doesn't pump well. Or dilated cardiomyopathy, where the heart muscle itself gets weak and the chamber enlarges.
Okay, that makes sense. Now, what about the other side of the coin, diastolic failure? The filling problem.
Right. Here, the squeeze, the contractility might actually be okay. The problem is the ventricle is stiff. It doesn't relax properly to let enough blood in.
So even if it squeezes out a normal percentage.
If less blood got in to begin with, the actual amount pumped out, the stroke volume is still low.
Ah, okay. So the ejection fraction could look normal or close to normal.
It often is. Yeah, that's a key differentiator. Think smaller starting volume, squeeze out the same percentage, you still get less total blood moving.
Got it. So what happens with the pressures and volumes here if it's stiff?
The pressure goes up quickly during filling. That end diastolic pressure, the EDP, is high because the ventricle resists stretching.
Even if the volume is necessarily huge.
Right. The EDV, the end diastolic volume, might be normal or even low sometimes, especially early on. The upper chambers, the atria, have to work harder, squeeze harder to push blood into that stiff ventricle.
And what makes the ventricle stiff like that?
A really common cause is ventricular hypertrophy. The heart muscle gets thicker, often due to things like chronic high blood pressure, and loses its flexibility.
Okay, hypertrophy. Thick and stiff makes sense. Now, we often hear left heart failure or right heart failure. Can it be both?
Oh, absolutely. It can affect just the left ventricle, just the right, or both. That's biventricular failure. Usually, though, when we say left or right, we're talking about where the primary problem started.
And is one more common, or does one lead to the other?
Critically, left-sided failure is the #1 cause of right-sided failure.
Really? How does that work?
Well, if the left ventricle isn't pumping blood out to the body effectively, blood backs up. Where does it back up from?
The lungs.
Exactly, into the pulmonary veins, the pulmonary capillaries. Pressure builds up in the lungs' blood vessels. Now, the right ventricle's job is to pump blood into those lung vessels. If the pressure there is high, the right ventricle has to work much harder.
So it gets strained.
It gets strained, can eventually enlarge, weaken, and fail itself. Domino effect.
Is there ever right heart failure without the left side being involved first?
Yes, absolutely. That's a condition called cor pulmonale.
Cor pulmonale.
Yeah, it's right heart failure caused specifically by a primary lung disease, like severe COPD or pulmonary hypertension from other lung issues. The problem starts in the lungs, increasing pressure, which then causes the right heart to fail.
Interesting distinction. Okay, so let's focus on the symptoms then. If left heart failure is so common and often leads to right, What does that backup into the lungs feel like for the patient?
Well, that increased pressure pushes fluid out of the capillaries into the lung tissue itself, into the air sacs. That's pulmonary edema or pulmonary congestion.
Fluid in the lungs. That sounds like it would make breathing hard.
Definitely. That's dyspnea, shortness of breath. It's harder for oxygen to get across into the blood when there's fluid in the way.
And what about that needing pillows to sleep thing? Orthopnea.
Right. When you lie flat, more blood returns from your legs and abdomen to your chest.
Oh, adding to the backup.
Exactly. Propping yourself up with pillows uses gravity to keep some of that fluid lower down, making it easier to breathe.
And sometimes people wake up suddenly gasping for air.
Yeah, paroxysmal nocturnal dyspnea, PND. Same mechanism, that fluid shifts around when you're sleeping, accumulates, and suddenly you can't breathe. Very frightening.
Wow. Okay. And when doctors listen to the lungs,
They might hear crackles or rails, little popping sounds as air moves through fluid in the small airways.
yikes. Any other lung signs?
Sometimes, if the pressure is really high for a long time, tiny capillaries can burst. Red blood cells leak out, and immune cells called macrophages clean them up. They get filled with iron deposits from the hemoglobin. We call them hemosiderin-laden macrophages, or heart failure cells.
Okay. Beyond the lungs, what else does left failure cause? You mentioned fatigue earlier.
Right. Less blood getting pumped out to the body means less oxygen delivery to muscles, organs, the brain. Leads to fatigue, weakness.
Makes sense.
Also, the kidneys notice they aren't getting enough blood flow.
And they react.
Oh, yeah. They kick in this system called the renin-angiotensin-aldosterone system, RAAS.
RAAS. Heard of that. It makes you retain salt and water.
Exactly. It's the body's attempt to increase blood volume and pressure. But in heart failure, it just makes the fluid overload worse. That contributes to the peripheral edema, the swelling.
Like Lydia's pitting edema.
Precisely. Pitting means when you press on the swollen area, it leaves an indentation for a bit.
And the nervous system gets involved too.
Yep. The sympathetic nervous system, the fight or flight system, gets activated. It tries to make the heart beat faster and stronger, which helps initially.
Yeah.
But it also constricts blood vessels and further activates that RAAS system, adding to the workload and fluid retention long term.
It's like the body's trying to help, but actually making things worse.
In some ways, yeah. It's a maladaptive response over time. We might also hear extra heart sounds.
Right.
An S3 sound, kind of a lub-dub DUB rhythm, often heard in systolic failure. It's thought to be the sound of blood rushing rapidly into a compliant, already volume-overloaded ventricle early in diastole.
Okay. And diastolic failure.
You might hear an S4 sound, more like a LUD lub-dub. That's thought to be the sound of the atrium contracting forcefully against that stiff, non-compliant ventricle just before the main heartbeat. An atrial gallop.
S3 for systolic, S4 for diastolic. Got it. Okay, now let's switch to right heart failure symptoms. We know it's often caused by left failure.
Or pulmonale, the lung issue.
Right. So instead of backing up into the lungs, the blood backs up where?
Into the systemic circulation, the veins returning blood from the rest of the body.
And what does that look like? You mentioned Richard's neck vein.
Jugular venous distension, JVD. The jugular vein in the neck becomes visibly full and distended because the pressure in the veins leading back to the right heart is elevated. It's a classic sign.
In the liver. Why was this enlarged?
Same reason. Blood backs up in the large veins, draining the abdominal organs, including the hepatic vein from the liver. The liver gets congested with blood, swells up. That's hepatomegaly.
Can that cause damage?
Oh, yes. If it's prolonged and severe, it's called congestive hepatopathy. The liver tissue can get damaged, even scarred, sometimes called nutmeg liver because of the appearance. It can eventually lead to cirrhosis, liver failure.
Wow. Okay. So JVD, hepatomegaly, and the leg swelling.
Yes, that peripheral pitting edema again.
Yeah.
Increased pressure in the systemic veins forces fluid out into the tissues of the legs, ankles, sometimes even higher up.
So edema can happen in both left and right failure, but maybe for slightly different primary reasons.
Exactly. In left failure, it's often driven by the RAAS activation due to low cardiac output. In primary right failure, it's more directly from the high venous pressure backing up, though often both mechanisms are at play when things get advanced.
Okay, this is complex. What about treatment? What can actually be done?
Well, there are treatments aimed at symptom relief and others that actually improve survival and slow down the disease progression.
Let's start with the ones that help people live longer.
Key players, there are ACE inhibitors, ARBs, those block parts of that harmful RAS system. Also, aldosterone antagonists like spironolactone, another way to block RAS.
Okay.
And certain beta blockers, specifically carvedilol, bisoprolol, metoprolol succinate, have shown mortality benefit. They seem counterintuitive, slowing the heart, but they reduce the harmful effects of that sympathetic overdrive.
But you have to be careful with those.
Very careful, especially if someone's in acutely decompensated heart failure, meaning they're really sick, fluid overloaded right now. Starting or increasing beta blockers then can sometimes make things worse initially. Needs careful management.
Got it. What about just helping the symptoms, like the fluid buildup?
That's where diuretics come in. Things like thiazide diuretics or more potent loop diuretics like furosemide. They help the kidneys get rid of excess salt and water, reducing congestion and swelling. Great for symptom relief.
Do they help you live longer?
Generally, no. They manage the symptoms, make people feel better, breathe easier, but don't fundamentally change the disease progression like the ACEs or beta blockers.
Okay. Any others?
Yeah, sometimes a combination of hydralazine and nitrates is used, particularly in certain patient groups, and it can improve symptoms and mortality. And there are newer drugs like neprilysin inhibitors, often combined with an ARB, that target other pathways like natriuretic peptides to help reduce strain on the heart.
Lots of options, it sounds like. Needs careful tailoring.
Absolutely. It depends on the type of heart failure, systolic versus diastolic, the severity, other medical conditions. It's very individualized.
Okay, let's try and quickly pull this together. Heart failure.
Mm.
The heart isn't meeting the body's needs.
Right. Either a squeeze problem, systolic, low ejection fraction.
Usually caused by heart attacks or dilated cardiomyopathy.
Or a filling problem, diastolic, often normal ejection fraction, but a stiff ventricle.
Often caused by hypertrophy, like from high blood pressure.
Good summary. And left failure backing up into the lungs is the main cause of right failure backing up into the body.
Except for cor pulmonale from lung disease.
Exactly.
Symptoms: shortness of breath, dyspnea, needing pillows, orthopnea, waking up breathless, P&D, fatigue. Those point more to left-sided backup, initially at least.
Correct. Crackles in the lungs, maybe an S3 sound.
And then swollen neck veins, JVD,
Right.
enlarged liver, hepatomegaly, leg swelling, pitting edema, point more towards right-sided backup. Maybe an S4 if it's diastolic.
You've got the main picture, and treatment involves drugs to reduce that RAS and sympathetic activation to improve survival, plus diuretics for symptom control.
Okay, let's look back at our cases, Lydia. 70. Previous MI.
MI suggests ischemic damage, a likely cause for systolic dysfunction.
Fatigue, dyspnea, orthopnea.
Classic left-sided failure symptoms from lung congestion.
Pitting edema.
Could be RAAS activation from low output.
And likely a low ejection fraction and maybe an S3 sound if we listened.
It all fits very well with systolic left heart failure, likely stemming from her previous heart attack.
Makes sense. Now, Richard, 81, smoker.
Smoking history immediately makes you think about lung disease, right? COPD, emphysema.
Fatigue and pitting edema. Okay, could be either side. But then JVD and hepatomegaly.
Strong pointers towards right-sided failure, high systemic venous pressure.
And if his ejection fraction was normal, but maybe imaging showed right ventricular hypertrophy.
Then you'd be leaning heavily towards right heart failure, and given the smoking history, likely cor pulmonale. The lung disease is probably driving the right heart problems.
So the next steps for him would be
Chest x-ray, definitely. Pulmonary function tests like spirometry to assess for lung disease. You need to confirm the lung issue.
wow. So same initial complaints of fatigue and swelling, but potentially very different root causes and investigations needed.
Absolutely. It really highlights that heart failure isn't just one thing. You have to dig into the why, the underlying mechanism to manage it properly.
It shows how interconnected everything is, especially the heart and lungs.
For sure.
Really makes you think, doesn't it?
Yeah.
Considering that close link, what other conditions, maybe ones we don't immediately associate with the heart, could actually be putting significant strain on our cardiovascular system without us realizing it until much later? Something for you to ponder.